Hi everyone, it's Dr. Steph and I'm back with part 2 of Family Medicine Billing. This is a recording of the lecture that I gave to the PGY2s at the McMaster Family Medicine program. But if you're a doctor coming from out of province or out of the country looking to be a family doctor in Ontario, this lecture would be relevant for you too. For part 1, I'll link it above and in the description below. So this lecture is going to be updated for 2024 as there's been a lot of changes to billing codes since the last time I did a lecture like this on YouTube. So in this lecture, we're going to talk about the differences in remuneration between fee-for-service, FO, and FIG models, as well as premiums and bonuses, billing rejections, and the highest yield part are the billing practice cases. This is where you really learn how to bill. Note that this lecture will be geared more towards fee-for-service and FIG billing, as FO billing has different rules that needs a lecture on its own. So this is the first part, which I've linked already. And this is like the whole series of all of the billing lectures that I have done. So if you are specifically watching for FO, you can watch these two particular lectures, but there are other ones that you can binge on your own time or reference to it throughout your practice. I don't have any conflicts of interest to disclose. So I always start with an audience poll, and I usually ask my PGY2s that I give the lecture to where you are planning to go next. Where do you plan to go when you graduate residency? And this is what a lot of my students have said. It looks like most people are still interested in doing general family practice, for which this lecture will be relevant for. But we're also starting to see some residents interested in emergency as well as focused practice. And as telemedicine becomes a bigger thing, several students have been interested in that as well. The second question I ask people about is a lot of the times they're starting to look at jobs and reviewing contracts. So for a lot of the new grads, it looks like a lot of them aren't sure yet exactly whether a contract is fair or not. And then the other thing I just want to point out is right now family medicine is in high demand. So don't just take any job offer that's offered to you. Really do the research and look at what is the best job offer for you, right? Don't sign a contract if it is sketchy. And the third poll is, as I develop more resources for practice management, I always ask my students what kind of resource they want to see more of. And this is what they said. So if you're watching this video and there's something that I haven't covered or you want to learn more about from the practice management transition to family medicine area, leave me a comment below and let me know what you would like to see. So throughout my lecture, I talked about these terms, fee-for-service, family health group, and family health organization. And those are the different types of practice models in Ontario to join if you're a family doctor. And so when it comes to learning about billing, of course, fee-for-service is the most simplest way to bill. Because what you bill is what you get, and you sometimes get these premiums as well. Family health group is kind of like one step up in terms of difficulty, right? So it's similar to fee-for-service, but you also get something called a comprehensive capitation. You have after-hours premium, which we'll touch on in today's lecture, as well as some special premiums and preventative care bonuses. And finally, as you can see here, if you plan to work in a family health organization, the billing becomes much more complex. And that's why, for the interest of time, I had a separate lecture video that I've linked earlier about that. So you can definitely see there's many different components of FO billing. When you keep in mind the different types of incomes, it's very much based on different roster sizes. So in a fee-for-service model, there isn't really a roster. So it's just based on volumes and how fast you can see patients. And that's why we usually see fee-for-service models in walk-in clinics or procedure clinics, for example. Now, when you look on the other end of the spectrum, you see a FO where the more you roster, the more you can earn. However, keep in mind that for working in a FO, it only incentivizes comprehensive care. It's not something for like rapid care. So don't just look at this slide and think, oh, I'm just going to roster a lot of people. You want to be able to provide good care to your patients, and that means also being available and having availabilities in your clinic for your patients. If you roster too much, that might actually result in lots of outside use, and that can decrease your access bonus, which I talk about in the FO video. They've also now capped how many people you can roster as well. The other thing to keep in mind is that increased patient burden or increased patient amount also increases administrative burden, and that is unpaid. So while you might be earning a high salary, you might also be working very long hours, evenings, and weekends. So think about that when it comes to how much work-life balance that you want to have. And always remember the golden rules of billing. Number 1, be honest. Number 2, documentation is a proof of your billing, so document well. And number 3, always ask if you're not sure. All right, so let's talk about premium modifiers and bonuses. So in the next page of your SGFP document, which I talked about in part 1 of this lecture, you'll see something called special visit premiums, and there's several of them. So for example, if you ever do a home visit, you can bill an extra bonus code for that. So for example, you visit someone in the evenings on a Monday, you can get a little bonus of $66, up to 10 patients that you've seen by home visit. And you can also bill a travel code to travel there to the patient's house. You can't bill the travel code to come back to your house. And that gives you about a $36 travel premiums. So remember to bill these two codes together. And the same applies for office visit premiums and hospital premiums. So for example, if you work in an office that happens to be closed that day, but you open it just so that you could bring your patient in, there is an office premium for that and a travel premium for that as well. And if you're like me who does inpatient consults, if you get paged to go to the hospital, there's also a premium for the time you spend going to the hospital to see patients and the travel fee for that as well. Now, there are also special premiums that come for people who work in patient enrollment models or PEMs, and all key terms are in bold and in blue in my talk. And these are just things that incentivize doctors to practice comprehensive care. So it's a bit higher for FO compared to FIG. So these are hospital premiums when you see patients in hospital as a hospitalist, for example, labor and delivery, and this one is accessible to FIGs as well. Office procedures, palliative care, home visits, long-term care, prenatal, and mental illness. So all of the ones that are in green are for FIG practices only, but FO practices have access to all of them. Usually, you don't really need to bill anything extra to qualify for these bonuses, with the exception of mental illness. So if you do see someone who has bipolar disorder or schizophrenia, anytime you see them, don't forget to bill this Q020 at least once when you see them, because this will tell the system, okay, activate the bonus that they get for about $1,000 a year for 5 to 9 patients seen, and about $2,000 a year for up to 10 and plus patients seen. And so you also want to remember that billing the diagnostic code with these codes as well, so 295 and 296. For all of the other ones, you don't have these specific billing codes to do. It's based on the billing codes you've billed. So for example, if you saw a prenatal patient, if you've billed P004s, P003s, it tells the system, oh, they've seen a patient for prenatal. And if they see a certain number of patients of this type of billing, they get the bonus. So anytime that you join a practice, one of the first things that you might have to do if you're starting from scratch is to roster patients. And what you need to know about rostering patients, especially if you're in a FIG or a FO model, for example, is to bill this Q200. This is a code that doesn't pay at anything, but it tells the system, okay, now to attach that patient to you. Q202 is billed if that patient is coming from a long-term care home. And you always want to remember this patient enrollment and consent form, because we talked about this in the first part of this lecture. This is the proof that you have that this patient is rostered to you. Now, if this patient is unattached and they were admitted to the inpatient for the past 3 months and then they came to you, then you can bill something like a Q023, which gives $150. It's an unattached fee in addition to whatever code you choose to bill for that first visit. Note that the numbering is a little bit weird. It's like 2, 4, and 5. That is because in the past, there used to be codes Q013, Q033. Now they no longer apply. So I've talked about a lot of Q codes, and Q codes, also known as modifiers, are codes that are paid specifically to doctors working in these patient enrollment models, but not like all of them, for example. Some of them might apply to FO, some of them apply only to FIGs, as you can see here. And so, this can be a bit confusing to people, right? And that's why I had that specific FO billing lecture all on its own. The other thing to note are these after-hours premiums. Those are something you should draw your attention to, because Q012s can be billed by both FIG doctors and faux doctors as well. And this gives you a bit of an extra 30% bonus for working after 5 p.m. or on weekends. And 𝗧𝗧𝗃𝗀, this is more so for CCM type billing models. One other thing to draw your attention to is the 𝗧𝗧𝗃𝗃. So that's when you get a patient, you roster a patient from Healthcare Connect, and they are a complex patient. So that gives you like $350, and it usually will say on that Healthcare Connect form to bill that. So remember, Q codes are very much of a faux billing thing, and they can be complicated. So that's why I just wanted to draw your attention to these. Now, there's also these things called preventative care bonuses, and if you're specifically in a faux type model, these might be ending in March 31st, 2024. So this might not necessarily be relevant to you, but so I'll just go through this very quickly, is that if you're in a FIG model, for example, you have access to this. If you're in a fee-for-service model, you don't unfortunately have access to these codes. And at the end of the fiscal year, which is March, sometimes you or your billing manager would look to see how many patients you've done flu shots, pap smears, etc. for. And if you have done, let's say, 80% of flu shots for all of your patients, you can get an extra bonus of $2,200. If you get the maximum of everything, that adds up to about $12,800 a year. Just one note is that there is a typo in this SGFP document. This should be Q102, not Q012, which is that evening premium. And there are also these things called tracking codes. So these don't pay anything, but anytime you see a patient for a flu shot or for a mammogram or something, you can build this, and it allows the system to track how many of these patients you've done mammograms for example. Some EMR systems actually automatically track it for you, but some don't. And so it kind of depends on your EMR. For example, my EMR, it doesn't. So I usually have to build these preventative care tracking codes. Okay, so now let's talk about rejections, because this is often something that can be very complicated. And when there's so many different billing codes to know, but with rejections, whenever you get a billing rejected, it comes in a code as well, right? And this can be frustrating for new grads. So the most common codes that I've noticed that I tend to get are either like version code of the health card is expired, or there might be duplicate claims, or maybe two people build the same thing on the same day, right? If someone double doctored that day. So this is the resource to go to look up what these different rejection codes are, so that you know how to fix them. Or if you have a billing manager, they can help you fix these codes and help you save time. Now, the most common reason why some billing codes get rejected is because some people have expired health card version codes. So when I started practice, I didn't know this until someone told me about this, and it's not really easily found information. So that's why I try to advertise it in my slides. So in order to find out someone's version code, without actually having to call that patient and ask them, you want to first get a PIN. And to get a PIN, you would email 24x7@ontario.ca. Once you get your 7 or 8 digit PIN, and you have that patient's health card number, you have the rejection code and some other patient identifiers, you can call this number. They will ask you for your PIN, and then you tell them this information, and they'll tell you the updated version code. This can often be time consuming, so this might be something you can delegate to your office manager or your billing manager. If you have a patient that comes from out of province, you can still bill OHIP because there is a reciprocal payment program, and you would just ask that patient for their health card number, and then you would bill that province. The exception is Quebec, where you might either bill the patient directly, and then the patient will request reimbursement from their provincial insurance provider, or you can send an invoice to their provincial health system. So now let's move on to talking about uninsured services billing, and this is more of the private billing aspect. So whenever you have a patient that comes from out of the country, they don't have OHIP, or let's say they don't have insurance. So you can think about invoicing them privately, and some clinics will have this particular document, the quick reference list from the OMA Physician's Guide to Uninsured Services, posted at their front desk, so that their front desk staff can point out the charges for certain things. And so these things are not covered by OHIP, and commonly they might be like sick notes, immunization forms, and so on. One thing to note is that when we're in residency, we're used to doing things for free because as a resident, we're salaried. But when you start joining a family practice, you start becoming a business owner. And with running a business, there are often a lot of things like overhead. So that overhead that you pay from your billings goes to covering the salaries of your secretaries, of your nurses, to going towards rent and equipment. And a lot of family practices are closing because they can't afford to run their business. And so when you think about, I kind of feel guilty billing or asking patients to pay privately for sick notes and things like that, you also have to remember that if it's not coming from these billings or from the uninsured service payments, it's coming from your billings. It's coming from your clinic overhead. So having these uninsured services and charging patients for them is one way to help you sustain your practice. And it also helps patients understand that your time is valuable, that there is a cost to the printer that prints out sick notes, to the paper, and to your secretaries that processes these sick notes as well. You also want to ensure that you stand up for yourself and you have boundaries, because if you don't set these boundaries early on, it makes it harder to set the boundaries later. So always take this advice with a grain of salt, because of course it's very much patient dependent. When you are the patient's family doctor, you know them the best, right? And you know that if they have some issues with socioeconomic status, you can make exceptions for that too, right? So just don't think about this as like a set rule. It's something that you can look at and change based on the specific patient situation as well. Now, hourly rate calculation, sometimes we might get asked to do things such as from lawyers' offices and things like that. And this way, because it's not covered by OHIP, you have to charge for your time. And how do you know how much you are worth on an hourly basis? Well, the OMA also has a calculator for that on their website. So in this particular example from their uninsured services guide, which I'll link in the description below, they kind of do a bit of a calculation for someone who works, let's say, 52 weeks a year minus 4 weeks of vacation, for example. So this is something that you can input your own information in on their online calculator to determine your hourly rate. But the thing to note here is that they suggest their hourly rate is $663, which you look at it and you think it's quite high, right? But you always want to remember that you've been in school for a decade. This is not necessarily paying you per hour. It's also paying for your experience as well. So think about it that way and understand the breakdown of why this is the hourly rate recommended by the Ontario Medical Association. Okay, so WSIB claims. So if you haven't encountered this in residency, the first thing that you need to know is about how to start billing WSIB. WSIB stands for Workplace Safety and Insurance Board. And this is when a patient comes to you and it's because they got injured on the job. So in order to bill WSIB, you have to register on this website, which I've linked down below, to get a WSIB provider ID. This is kind of like your billing number. And then when you're ready to submit, you can use the portal, WSIB portal, to make these submissions online. So remember how I said that WSIB is only for when a patient comes to you for injuries at work? Well, companies, to become an employer in Ontario, they have to pay into WSIB. And this is kind of like an insurance for the companies, such that if a patient gets injured at work, it's WSIB that covers their recovery instead of that company themselves. And so let's say a patient comes in and they said, okay, the injury occurred at work. If it did, ask them if they intend to claim this WSIB. If they do, you can bill the Ministry of Health with WSIB as the insurer. So on your EMR system, you can change the insurer to OHIP or to WSIB, for example, and you want to complete something called a Form 8. After 2 weeks, you'll get a check or a direct deposit. If a patient got an injury at work, but they don't intend to claim WSIB, in this case, you have to charge them privately based on what we learned earlier about the uninsured services. Unfortunately, you can't bill OHIP for a work-related injury. So what is this Form 8 that I've highlighted here? This is what a Form 8 looks like, and it's a health professionals report form. If you do it online or submit it online, it pays $85, and if you do it in person and if you do it on paper and you fax it in, you get paid $65. The other form that's WSIB related to know about is the FAF, and this is more so when the patient is ready to return to work. So this pays about $40, and it's kind of an update to their employer to say like, okay, now they're able to go back to work fully or with modified duties. The WSIB has its own fee schedule as well, just like how there was the SGFP document I talked about earlier. This is the WSIB fee schedule for everything that to determine all of the different forms and how much you would get paid for them. Okay, so we covered a lot of content in the last two lectures. So now let's move on to the practice cases. If there was anything that you weren't sure about, here is the time to really help you solidify that knowledge and to help you with that with your understanding. What I would suggest is that you have the SGFP document on a different screen and pause the video so that you can try and answer the questions yourself. And then unpause, and then you'll see the answer come up. So the first scenario is you cancel your clinic that day to do a house call for an elderly patient with severe arthritis and dementia. What do you bill? Here I would pause the video, look up your SGFP document and see what you would bill, write it down, and the answer is C. So the reason why is that this is a trick question. There are some codes in the SGFP document that is now obsolete, but it hasn't been taken off the document yet. So I like to use these cases to kind of highlight areas where there might be typos or obsolete codes so that you remember them. So A901, which is the house call assessment, is now obsolete, so that's why we used A900. And for the B992, it's because you canceled your clinic that day, so you sacrificed your office hours, and you did a house call, so you get a travel premium as well, which is B961. All right, scenario 2. So you canceled clinic to respond to an urgent house call between 3 to 4 p.m. on a Wednesday. The patient has palliative breast cancer. What do you bill? So pause the video, write down your answer, and the answer is A. So this is a tricky question for a lot of residents because there could be multiple billing codes that you could use, and some of them could also all be right. However, you also want to think about that if you have multiple right billing codes to use, choose the one that pays more. So in this case, because it's a palliative patient, the K023 pays $62. And then you have your B998, which is the $82 palliative care special visit premium, as well as a travel premium for this as well. Okay, scenario number 3. You do a complete physical for a 50-year-old male, which takes 20 minutes, and you counsel them, I guess if you counsel them for 20 minutes as well, on their cholesterol, and you provide them with a fit test. What would you bill? So write down your answer and pause the video, and the answer is B. And so in this particular case, even though a complete physical, you could bill potentially K131, because you also did a counseling, let's say for 20 minutes, then if you compare the two codes, K013 does pay a bit more than K131. So when there's two right answers, choose the one that pays more. And then the Q150, this is just for giving them their FOBT, or their fit test. All right, scenario 4. So you work in a FIG and you cover Saturday walk-in clinic. You see a patient with a cough and cold. What do you bill here? So pause the video, and the answer is A or B. So there's two right answers here, and so let's cover this in a bit more detail. So first of all, the Q012 is your after-hours premium, so that gives you a little bit of a bonus, and that applies to both A888 and A007. So the reason why A007 and A888 are both correct, although personally I would say that A888 is a little bit more correct here, is because A888 is an out-of-basket code. So if you're working in a walk-in clinic, and let's say a patient that's not yours, they see you in person and they are already rostered to a FO, billing the A888 will not negate the billing of that other FO doctor's patient for coming to see you. A777 would, because it's an in-basket code. So either way, you would still get paid the same, regardless if you billed A or B, but it just kind of depends on being collegial to some of our colleagues who work in a FO practice. So this is what I mean by the A888 being out of basket here. All right, scenario number 5. So you are taking on a new patient from Healthcare Connect with a complex medical history. What would you bill? Pause the video, write your answer, and the answer is B. And so remember what I said earlier about Healthcare Connect. You can bill this extra $350 in addition to any of your meet and greet visits. So let's say if you usually bill A007s for your meet and greets, you can bill that as well. All right, scenario number 6. So a patient comes in with a steroid joint injection in both knees. What do you bill? Pause the video, write down your answer, and the answer is C. So In this particular case, the first joint will pay a little bit more, so $20, and the second joint pays a little bit less at $19. And because it has this little symbol right here, so don't forget about these symbols that we talked about in part 1 of the videos, to add a tray fee, and that can really help offset the cost of your supplies. Okay, scenario 7, WSIB. So you evaluate a 33-year-old typist with a history and signs of lateral epicondylitis due to work. You conduct a history and physical on this condition. They also ask you about a rash, so you prescribe a steroid cream and physiotherapy. What do you bill in this case? So write down your answer and pause the video, and the answer is A. So in this particular case, because you conducted a history and physical, for the skin rash, this is covered by OHIP. So that's why you can bill an A007 to OHIP with the diagnostic code for the skin rash. Now, because you also saw them for a work-related injury, you can't bill OHIP for the work-related injury, only to WSIB. So whenever you're changing the insurer, you don't put OHIP, you put WCB, Workers' Compensation Board. And you would bill A007 to WCB. Then you would do your Form 8, and then you would submit that online, and then you'll also get paid by WSIB for filling out the Form 8 as well. So hopefully that makes it a bit more clear for you. Let's do another WSIB example. So let's say you followed up with that previous patient, and now in 4 weeks, they don't have any improvement. The patient now has a WSIB progress form to fill out. Which form would that be, and which one do you bill for? So pause the video, write the answer, and the answer is B. So this would be a health professionals report, or Form 26, and a lot of people will write FAF instead. This is more so for if the patient has recovered and is ready to go back to work. In this case, the patient hasn't improved, so probably needs more time off. All right, scenario number 9, emergency billing. So it's a 55-year-old male with chest pain, and they present to the emerge in the evening on a weekday. What do you bill? One thing to note about emerge billings is that the folks I've met who work in the emerge, they don't really use the SGFB document. They use the EM London website, which has better organization of the emergency billing codes. So if you're watching this, you can feel free to Google or type in this link for you to find the answer. And if you write the answer down, and the answer is H132, which is a comprehensive visit for the weekday evening, 5 p.m. to midnight. Some people might ask, what's the difference between H132 and H133? Some of my emerge colleagues have told me that they bill H132 is if they get a really like a med student level visit where they get the social history, they get the family history. So that might actually be relevant in this case for chest pain. You might want to ask about family history or smoking and things like that. Multi-system is as it's described. So if you examine multiple systems for that visit. All right, scenario number 10, another ER case. So if the emergency doctor sees a patient for multiple systems assessment and admits them to the hospital as covering overnight, what do you bill? Pause the video, write down your answer, and the answer is A. So your multi-system assessment, H133, and then you admit to another provider overnight, which is H105. All right, scenario number 11, emergency billing. So you see a patient in the emerge for a shoulder dislocation at 1 a.m. What do you bill? So the answer is B, and this is because for a shoulder dislocation, you might have to assess multiple systems, maybe the nervous system, the musculoskeletal system. Depending on the nature of the injury, maybe you're examining their, cranial nerves, or they're examining for head injury. So H123. The D016 refers to if you give them anesthesia, and the E413 refers to the time, which is 1 a.m. And that gives you a bit of a bonus. All right, next scenario, number 12. So it's an OB example. You do a delivery at 1 a.m., having augmented the patient. You now do a postnatal visit in the hospital. What do you bill? So pause the video, write down your answer, and the answer is C. And so here's the reason why. So because you did the delivery, the vaginal delivery, it's a P006. And then the E411 is kind of like a bonus for doing a delivery at the visit. And E410 is a premium because you worked during the night time. A P023 is when you have the oxytocin augmentation. And a P007 is when you did your postnatal visit. So again, just as a reminder, this is a typo here. It should be 5 p.m., not 5 a.m. And the total amount that you would receive is $14.94 for that delivery. All right, let's do another OB example. So let's say you did a delivery at 7 a.m. and now you attend labor and assist at C-section, which took 1 hour, started at 9 p.m. Note that for this question, it's specifically asking you what you would bill for this labor and assist. So pause the video, write down your answer, and the answer is D. So for the attendance at labor and delivery, you get a P009, and then the E409 is that bonus that you get for working later in the evening. So the total amount you would receive for this particular visit is $748.05. Okay, so one more OB visit. So you do a prenatal during after hours in a 𝗧. What do you bill? So write down your answer, pause the video, and the answer is D. So this is a bit of a tricky question and highlights how working in a 𝗧, the billing might be very different than working in a fee-for-service or FIG model. So remember that the P004 or P003, these are out-of-basket codes. And so you get the full amount for this. Whereas working in a 𝗧 A007, you don't. You only get 19% of this billing code. So if you calculate how much, which one pays more, even though all of these are theoretically right answers, any of the out-of-basket codes in this case would pay more. Unfortunately, these out-of-basket codes are not eligible to combine with a Q012 codes, these ones right here. So for more info, this is the video to watch as a refresher, and I'll link that above. Okay, so now you're doing a prenatal in a FIG. What would you bill here? Write down your answer and pause the video. And the answer is B. So in a FIG, it doesn't really matter if it's out of basket or not. That doesn't really apply. So in this case, you want to bill one of these codes in here because you get not only get the premium added to it, you also can get the after hours bonus as well here. All right, scenario number 16, diabetes. So you see a diabetic patient for their 3-month diabetic care visit for the first time. What do you bill? Pause the video, write your answer, and the answer is B. So remember, the K030 is your diabetic management, and you can bill 4 of these per year, per patient. And let's say if you saw a patient more than 3 times with this particular code, you can now, if you're in a patient enrollment model, you can add on this bonus Q040, which gives you an extra $60. All right, next scenario, smoking. So if you see a patient for a cough and you find that they smoke 1 pack per day, you counsel them on the nicotine patch. What would you bill for this case? Pause the video, write your answer, and the answer is C. So the A007 is for billing for assessment of the cough, and then the E079 is for asking them about smoking and counseling on the nicotine patch, and that gives you an extra $15.40. Okay, procedures. So in an office visit, the patient is concerned about a changing mole on back, and the excisional biopsy was done at the same visit. What do you bill in this case? Pause the video, write your answer, and the answer is none of the above. So the reason why is this is one case where you might want to set yourself a reminder or a task on your EMR system. If the biopsy comes back as malignant, then then you get paid a different amount. So malignant lesion, for instance. So if you hold on to it, then you can bill for a higher amount compared to if you just done the excision and billed it the same day. Now, the caveat to this is that sometimes pathology reports can be very slow in coming back. And so you don't want to make sure you delay this more than 3 months, because if you have billings that are delayed more than 3 months, you can't really backdate them further than that, and it might not end up getting paid out. So that's just something to be careful about. All right, scenario number 19, it's another procedure one. So let's say you saw a patient on video with a mole that is changing color. You're not sure if it's malignant, and the nearest dermatologist is 3 hours away. You take a picture with your camera and you submit it for assessment through the e-consult service, and you receive an opinion back in 4 hours. So pause the video, write down your answer, and the answer is A. So the A007 plus K300, that's your video visit code. And because you used e-consult, which I highly recommend every family doctor sign up for, because you get the opinion from the specialist back in like 2 to 3 days, you can bill for that that time you spent doing the e-consult. So it's a K738 because you were the referring physician. So that's about an extra $16. All right, scenario number 20. So a patient comes in with a plantar wart and you decide to apply liquid nitrogen. What do you bill? So write down your answer, and the answer is A. So the A001 is your visit where you kind of discuss wound care and things like in the procedure with the patient. And then a Z117 is the chemical wart. Some people might, depending on how long you talk to the patient or how much detail you talk to them about, some people might also bill an A007. So A or D could be correct in this case as well. And if you applied Canthicur instead of liquid nitrogen, you can still bill a Z117 as well. All right, procedures. So if a patient comes in with tennis elbow that is unresponsive to NSAIDs and physiotherapy, and you decide to see them for follow-up, and you decide to inject them with cortisone, what do you bill for this case? So pause the video, write down your answer, and the answer is B. So in this particular case, because you did an injection of one site, you can add on the G370. Who pays for the cortisone? It depends. So some clinics might charge patients for it because it is a fee, that's a supply fee for your own office. But some other doctors will give the patient a prescription, and the patient fills the prescription and brings the cortisone to be injected as well. So every clinic is different. When you start joining a clinic, you can ask them about that as well. So that brings me to the very end. Feel free to leave me a comment if you have any question, and you can always reach out to me at Breaking Bad Debt on YouTube and Instagram, especially if you are a lecturer and you want to use my materials in your billing lectures as well. Thank you for watching, and don't forget to like and subscribe to be notified of future lectures.